Hi everyone, my name's Alex. My topic today is changing thyroid ultrasound reporting practices, and I'm going to be looking at this using some of our course content areas: leadership, change, and gender. So here's an outline of what I'll talk about today, first starting with the case description, and then just some reflection on the case. So what went well, and how can this be applied to future situations, and also what didn't go so well, and how could this be done differently. And the course content areas I'm going to focus on are leadership, change, micro skills of change, as well as gender. So first, the case description. So the case is about an attempted change initiative involving the Department of Surgery, Department of Radiology, and Division of Endocrinology at multiple sites in the Fraser Health Authority, and I am an endocrinologist working there in British Columbia. So some background info before we dive into the case. Endocrinologists and surgeons will treat patients with thyroid nodules, and we make treatment decisions based on various factors. One of the most important is, what does the nodule look like on an ultrasound? So we do rely on the radiologist's interpretation and their report of the thyroid ultrasound in order to make decisions, and these decisions are usually, do we do nothing, do we have to follow with further imaging, or do we have to do a biopsy of the thyroid nodule? So about 4 years ago, this was just prior to me being hired on, the group of endocrinologists at another hospital in the region identified an issue at one of their meetings and something they had been encountering, which was that thyroid ultrasound reports were lacking many of the details they needed to properly assess the risk that a nodule could be cancer. And we do have guidelines to outline what these important elements are. So after they discussed locally at their particular site, the leader who started the change initiative contacted the group of endocrinologists at our hospital to talk about the issue at our division meeting. And this was around the same time I had just finished some research. I had done a retrospective review of looking at these thyroid ultrasound reports in our region and looking how many elements were often included in these ultrasound reports. And I actually found that largely these reports were not complete and were underreporting these important elements. And not only that, underreporting was associated with delays in biopsy and surgery for these nodules. I have my paper in the reference section if anyone's interested in getting any more info on that. So both groups of endocrinologists felt a change was needed. So our leader from the other site contacted one of our high-volume thyroid surgeons, as well as the department head at one of the hospitals in radiology, to set up a meeting to identify this as an issue. Plans were made to develop a consensus statement based on the current thyroid guidelines, and these consensus statement was contributed to by all the group of endocrinologists, including myself, as well as the general surgeon. This was then brought back to the radiology department head, who reviewed the document and reviewed it with their department and agreed on what should be required to be included in ultrasound reports. So everyone had agreed on this consensus statement. So since the development of the consensus statement, there have been some improvements noted in how many details are included on ultrasound reports, but this is not consistent, and we don't really know the degree to which this has improved, so no one's really looked at this outcome at all yet. Also to note, at some point there were some issues in the radiology department. People weren't getting along, there were communication issues, there were disagreements about other things going on, which I think derailed their focus from this particular change initiative. I should also note that after our consensus statement was developed, an alternative scoring system for thyroid nodules called Thyroid came out and was starting to be used more frequently and may be sort of the newer standard. And now this Thyroid score is being used by some of the radiologists in their reports, which does help us triage nodules and help us treat them appropriately, but is different than our initial consensus statement based on the American Thyroid Association guidelines. So where we are now, has the change initiative failed? Has it stalled? I guess up for argument, but certainly we need an intervention. So I'll move on from our case and then we'll reflect on this a little bit. I'm going to start off with what went well. So first I'm going to look at this through the content of leadership that we did in our course. So I do think our leader used aspects of transformational leadership. So I think we can all remember the 4 I's that are included in transformational leadership, which are idealized influence, inspirational motivation, intellectual stimulation, and individualized consideration. So inspirational motivation is how transformational leaders create a vision, establish effective communication, and encourage followers while giving them autonomy. And I do feel that our endocrinologist leader gave others autonomy in the process, valued their input and expertise, and tried to establish effective communication by bringing different subspecialties and specialties together and trying to agree on a clear vision for what we wanted these reports to have included in them. Individualized consideration is how transformational leaders attend to the unique needs of their followers and listen to their concerns. I do think our leader was open to input from individuals and open to different needs based on the background and open to discussion about concerns for what our end goal should be. So I do think these 2 I's were done well by our leader. So why is this a good thing? So transformational leadership has been shown in many different settings to be effective compared to other leadership styles, but specifically to our situation, it has been shown to be effective at lower level leadership positions as well as in the public sector. So there was a meta-analysis published in 1996 by Lowe et al. That found that transformational leadership behavior is more effective when compared to transactional leadership in multiple settings, but also these relationships were stronger in the public sector when compared to private organizations. They also found that the relationship between this leadership style and effectiveness is equally strong at both lower and higher levels of the organization, and so this would apply to both low and high level leaders. So I do think this is relevant because our leader was a lower level leader. She was sub-departmental and also working in the public sector. So for those reasons, I think that literature does support the use of transformational leadership for our leader. We also know that transformational leadership has lots of evidence in healthcare settings. So some of the studies I'll talk about, one is by Gable, published in 2012, and this showed that transformational leadership is associated with greater staff satisfaction, reduced burnout, and improved perception of leader effectiveness when compared to other forms of leadership. And these were studies in the healthcare field. Another study by Zurazagar et al. Also found, when looking at physician leaders, that transformational leadership styles were positively associated with perceived effectiveness. There was also significant association between transformational leadership and achievement of practice changes. So for those reasons, in our healthcare setting, I think transformational leadership would be an asset. And then lastly, I'll just touch a little bit on team performance. We know transformational leadership is associated with improvement in team performance. So inspirational motivation encourages shared vision and commitment of the team, and these constructs contribute to team cohesion. This was looked at a study by Dion et al. They also found in that study that individualized consideration is associated with an empowered team environment and improvement in communication. And in turn, team cohesion and better communication will contribute to improved team performance. So as in any of these types of change initiatives, team performance, I think, is pivotal, especially in our situation with so many different areas and specialties involved. So I think transformational leadership was a good choice from that standpoint as well. Next, I'm going to talk a little bit about Kotter's 8 stages of organizational change and go through what did we accomplish here. We may not have achieved all of these stages, but I will go through the ones that we did. So I do think a sense of urgency was established. So I happened to be doing my research in this area at the time, which may have helped feel that the status quo of these current reports were not satisfactory, especially because of potential negative outcomes may be associated with underreporting in these reports, and just being identified as an issue at the other site as well. So as the endocrinologist, we did identify this certainly as an issue and had agreement with the general surgeon as well as radiology colleagues. So I think this was a good thing that happened in our change initiative. I also do feel a powerful guiding coalition was formed. So we did have two endocrinologist groups involved, as well as general surgery and radiology. And included in our group was the endocrinology division head as well as the radiology department head. So these are powerful people that could certainly influence our outcome. And I think the important stakeholders were included, including the treating physicians. So myself, our group, as endocrinologists, the general surgeons, plus also those people that have to directly implement the changes, which would be the radiologists. Next is creating a vision. I do think we did have a vision that was quite clear by way of the consensus statement. So it was in writing, what did we want included in these reports? And this was based on the best evidence at the time. We also got approval from the different stakeholders involved to see that they agreed upon the consensus statement. So I think a good vision was created. So because our change initiative was not successful, we may have a little bit more to focus on in this section of what didn't go well and what could be done differently. So going back to leadership, I did say that our leader had some aspects of transformational leadership, but there are certainly some aspects that I think could have been improved. And these were idealized influence and intellectual stimulation. So I do feel for idealized influence, our leader was respected and trusted, but I'm not sure to what degree it was felt that she had extraordinary capabilities compared to other colleagues. I also don't think she focused on developing self-esteem and self-determination of the followers. For intellectual stimulation, overall she did encourage a new approach, but I don't think that creativity or innovation were inspired by the leader. I'm not sure if this is just the nature of the task where we were going by guidelines and systematic changes were the goal, but this may come up in a little bit later slide here. I just think overall the leadership was not strong enough to overcome some of the challenges and to effectively lead all the people involved from all the different specialties. And I think this lack of effective leadership certainly contributed to the inability to accomplish the end goal. So next, we'll continue on with the Cotter stages and some of those that we did not accomplish and potentially some of the reasons why we may not have accomplished them. So here are the 5 stages I'll focus on here: communicating the vision, empowering others to act on the vision, planning for and creating short-term wins, consolidating improvements and producing more change, and then finally institutionalizing new approaches. So Cotter outlined some pitfalls that can happen during some of his stages of organizational change in an article from the Harvard Business Review in 2007. So the first stage that we had issue with was communication of the vision. And here the pitfall is under communicating the vision. So here we made the consensus statement created by multiple people and approved and disseminated to other key stakeholders. But this was sort of done on a single time basis with one meeting. There was no real ongoing, frequent, and consistent communication that I think was necessary to keep people on track and updated as to the progress of what was going on. The next stage we had issue with was empowering others to act on the vision. And here the pitfall is failing to remove obstacles to the new vision. So I think there were 2 aspects to this. So the first was the issues occurring in the radiology department. So there were some issues with the team dynamics and communication from that standpoint. And I think that process stole from the focus on the current initiative moving forward. And I don't think we knew enough about what was happening at the other site or felt it was our place to address that. But I think a powerful leader would have delved into that and tried to focus on that and remove that obstacle. Second set of obstacles I don't think we addressed, I think first would have had to be identified. So I think as endocrinologist leader, identifying what could be possible barriers for radiologists adapting a new system. Would it be lack of time, decreasing efficiency, their current dictation system, just general lack of awareness or knowledge? So I don't think we knew enough about what the potential barriers could be, and without knowing these obstacles, how would you address them? Next would be planning for and creating short-term wins. So here the pitfall is not creating short-term wins, and I don't think short-term wins were created here. So we sensed that more radiologists were including more elements in their reports. The reports were getting better, although not consistently, but we never measured this and proved that, you know what, our initiative is making a change which can help progress the change forward. Next, for the Cotter stage, consolidating improvements and producing more change. Here, the pitfall is victory being declared too soon. And this is where small improvements were taken as victories. And I do think this happened to us where, you know, as an endocrinology group, getting the radiologists on board to identify this as an issue and to think that, you know, let's work on this, that seemed like such a victory in itself. And I wonder if some of that forward motion stalled a little bit after this, because we do know that declaring victory too soon can certainly steal momentum of a change initiative. And I don't think we kept in mind that transformation will usually take years, not weeks or months. And then finally, the last stage of Cotter's stages is institutionalizing new approaches. So here the pitfall is not having changes anchored in the culture. So I never thought we really got to this point. But it is important to touch on, especially in the healthcare field and with our change initiative, that even if we had been successful at our site, having sustainable change requires this change spreading to neighboring systems. So that's something to keep in mind when we focus on this change initiative moving forward. I'm going to touch a little bit on lack of adaptability. So being innovative and flexible is important, and I think especially with new developments, new technologies, and new evidence in the healthcare field, this is really important. And so in our case, a new scoring system came out, the Thyroid score, after the initial consensus statement was made and our change initiative was already underway. But we never really addressed it or adapted to that new information. I'm wondering if better use of transformational leadership would have encouraged innovation, and could this have possibly allowed more flexibility and adaptation of our original plan? So the ability to adapt is necessary for a successful change. So this was a model by Zulig and Bosworth made in 2015, and this was specifically about change in healthcare settings. So it's a bit different from the Cotter's stages of organizational change. This is healthcare specific. So the stages here are plan, do, study, adjust, and sustain. So with the plan stage, which is number 1, you have to seek commitment and support, think about how this will be scaled up, look at the ongoing environment, cost, and resource requirements, and discuss if you're going to utilize existing things versus coming up with your own new design and implementing that. The next stage is do, so determining efficacy on a small scale. Third stage is study. First, we want to know, should this be scaled up? Is it safe, clinically effective, and cost effective? And how feasible would it be to scale up? The last 2 stages I'll focus on a little bit more here are adjust and sustain, because I think we really didn't do these things here. So here, adjust is its own category, likely because this is in healthcare. So you always have to be adapting, adjusting, and simplifying. And then again, emphasis on sustaining change. So capacity has to be built, interventions have to be embedded in core policies. Evaluation of clinical and implementation outcomes has to be ongoing, and I think this was really important in our case. And funding has to be secured as well. And then lastly, I'll touch a little bit on gender. So from our gender portion of our course, we know that female leaders may have unique experiences compared to male leaders. And although healthcare and education settings tend to be more congruent with quote female unquote characteristics, women will face more discrimination in more masculine environments and when they're being evaluated by male followers. So in our situation here, it was more male-dominated environment because of the radiology and surgery departments having more males, and the majority of our followers being male. Because of that, I'm wondering if that could have impacted our leader's effectiveness as a female, and if this led to us not being successful in our change initiative. So I'll wrap up here. So even though we weren't successful in our change initiative, I do think a lot can be learned. So what can we do again in future? So certainly, again, using aspects of transformational leadership, although hopefully all 4 of the factors of transformational leadership should be implemented. I think we established a sense of urgency. I think our coalition was strong. It had the appropriate people involved from the appropriate areas. And I think we initially outlined a clear vision that was agreed upon by everyone involved. What to do differently? So I think communication of the vision, it certainly wasn't done enough and frequently enough on an ongoing basis. I think more research needs to be done up front as to what possible barriers we might come up against and how to address those as we go along. Creating more short-term wins, and that requires ongoing evaluation. Don't declare victory too soon. That will steal away momentum. And using techniques to ensure that we sustain change. Having different departments and different sites involved once we prove our initiative is working at one site. And of course, in healthcare, having to reassess along the way and ensure that we can adjust and adapt our plan as we go along. Thanks so much, everyone, for listening. I look forward to your comments during our talks online, and here are some of my references. Thanks again.